on to the last presentation. Thank you so much for holding on. I see that a lot of people couldn't stay longer, but yes, Aditya, go ahead. We cannot have a VR surgical session without a buckle. Thank you, Praveen ma'am.
Dr. Aditya, looks like you're on mute.
Aditya muted.
Yeah, sorry. I said, thank you, sir. Thank you for including me in this elite group of speakers, and I would just try and stick to the time. Just a minute. Yeah. So this is, as the the title suggests, this is mutton dressed as lamb, or old wine in the new bottle. All the speakers here are obviously experts in scleral buckling, and after having seen such wonderful videos on extensive surgery, I thought, and Dr. Jay also agreed, that maybe we can introduce a new dimension, and that is minimal surgery. So, my father, I've had the fortune of working with my father, and he has been using minimal surgery for the past 42 years and with very good results. So I simply imbibed whatever he had to give. So, vitrectomy has introduced, a whole new perspective to the management of retinal detachment. But even today, we believe that minimal surgery to attach a detached retina is still a valid option. And by minimal scleral buckling, what we actually mean is achieving retinal reattachment through the use of minimal surgery with maximal preoperative workups. Now, this might not be possible in a very busy OPD, devoting 20 or 30 minutes to every patient with detachments. And from what, the cases that we saw today, the, scleral buckling might just be an alternative or, a complement to it, but it cannot be the sole method of surgery. But anyway, minimal surgery would involve limited conjunctival peritomy, say just in one quadrant, tagging maybe just one or two muscles, restricting the number of sutures, minimal cryo. In fact, what some people say is you actually localize the break so that the indentation takes place pre-cryo, not post-cryo, to prevent or minimize the onset of PVR. So also restricting the number of buccal segments, no encirclage, no drainage, and minimal post-cryo indentation. So some people, the prudes, so to speak, even pass sutures prior to applying cryo. So I think except for the radial suturing, which is the only actual difference between, regular scleral buckling surgery, and of course the use of a sponge. So a lot of people have misgivings about the sponge, the infection, displacement, exposure, and so on and so forth. But I think if it is properly utilized, I think it still has a lot of role to play. So this is just a sponge being put in place, and first you just use a slip knot, confirm the location. The challenge here is not the surgery per se. The challenge here is perhaps the precision in location or localization of the break, so that you can minimize the number of tools or instruments that you need to actually perform the surgery. So here, what we are actually doing is you put the suture in place, and then you see that the indentation is not enough. You can actually put a second suture adjacent to it, using the 1 or 1.5 or 2 millimeter principle, of course, that is beyond the diameter. And the size of the buccal is, of course, determined by the size of the break. So if it's a single break RD, one suture, one muscle or two muscles being tagged and one quadrant open, it is a possibility, and it does, work. So likewise, just a couple of cases to share. So this was a 46-year-old phakic male, clear lens. As you can see in the left bottom picture, there was a horseshoe tear very close to the arcade. So we actually put in a radial buccal to good effect. And this photograph to the bottom right was taken about in the middle of a laser session on top of the buccal. The patient, started panicking. So we gave him a 15-minute break, and we utilized it to get a photograph. So anyway, what we see here is very good indentation with this buccal. And the second advantage of using a sponge is, of course, continued indentation. It continues to, give better indentation, as can be seen in this patient with a chronic RD. And the subretinal exudates are actually a testimony to the chronicity of the RD. But this settled very well. Eventually, this patient recovered 6/9 vision. So what we see is excellent indentation with the use of a sponge. Also in this case, as you can see, massive indentation. Now in this patient, again, a 39-year-old male, phakic male, had been advised vitrectomy elsewhere because the break was not very well localized. And what we saw is that the break was adjacent to the superior edge of the medial rectus muscle, 3 o'clock. But it was not very well localized. Even my father, who has been doing buckles all his life, was not very convinced about the location of the break. But I said, it's a 39-year-old make, let's go ahead, let's give it, let's take a chance. And we were fortunate enough, by God's grace, to have settled the retina without any further intervention. So this is just a 3 or 4 day old surgery. So it worked very well. Even in these cases, for example, you see this patient with subretinal fibrosis, subretinal destruction of the outer retinal layers. Now, this is a one-eyed patient whom we have been following up for 38 years. Of course, and I did not do the surgery, it was my father who did it. But this patient has maintained 6/18 vision over 38 years, no oil, no hassles. Again, chronic RDs, this is just a sketch of the RD, and this is the break. You can actually see it here. And this is post-settlement where you can see that the fluid has gone off. So these RDs are about 8 or 9 months old. They can still, benefit from a buckle. So again, multiple breaks also means multiple buckles, but that does not necessarily mean that it is, it fails. In fact, it can be used to very good effect. And even, in this day and age, buckle readjustment does have a role to play. So again, in this case, as you can see, we had to actually shift the buckle posteriorly, but again, to good effect. Yet another patient, 8-year-old boy, no vision for the past 9 months, diagnosed with chronic RD, even PVR setting in, as you can see here. This is just a sketch of the same patient, and here, of course, you can see an obvious evident ERM. But the patient, this retina settled very well. 9 months or about a year later, he had actually redetached and received a vitrectomy. But for a year, he enjoyed very good vision, maybe 636 or something from light perception. So just a quick presentation, Dr. Jay. What I came across is that in this high-tech age, buckling does play a role, and that minimal surgery is the way to go, because everybody wants a quick outcome. Nobody has time, to actually put in an encephalitis. Like Dr. Lalit Verma said, we are getting lazy with buckles. But even today, I think, especially for phakic patients, buckling, should be the first step in the management of any retinal detachment. So thank you very much.
Excellent presentation, Aditya. And yeah, it's great to learn these key skills, especially from your dad. That's good.